Hey, Dr. Nurena, hi.
Hey, and of course, call me Kathie, Dr. Randall.
I will. And I, of course, am Linda. And to everybody who's listening to us, I am Linda.
Yes.
She's Kathie. um, I have a question for you. And for everybody listening, Kathie doesn't know what question I'm going to ask her. We decided that we had some questions that we're always wondering about our professions. And hey, I'm a veterinarian and I do this. What do you do as a physician? And so the question that I have for you is, I'm finding that as we got our talk together for chat, so I started second guessing myself a lot. As I would proceed through an appointment, I would start thinking, if I had handled that differently, I might have had a different outcome. Or once everything came to fruition and I got the lab tests back, or I found out something else at the end of the conversation, I keep thinking, well, given that outcome, I should have handled it differently. And I don't know what you call them, but we often call them doorknobbers.
Oh, yeah.
People who get to the door and they hold on and then they say, oh yeah, and.
Oh, we could probably talk for hours about just about that and that phenomenon.
Mm-hmm.
And it's,
And so it's really hard. And so I was just wondering what happens in your exams now that we're in this behavior in a medical setting.
it's really layered complexity for me because I see patients in the office and we have those moments, but I also teach residents. So I'm often, how do you handle that doorknob? That, oh, by the way, is often what we call it. And so I do think there's a lot that we talked about that is actually does change my perspective a little bit. So in my encounters, I think because you and I, what we're talking about for chat is behavior in healthcare, and we talked about trauma-informed care and a lot more social things, or, some kind of behavior than pathology and medical. So it has changed, and I do find myself thinking more about the patient perspective. And I find myself when I'm precepting and working with residents, we're talking a lot more about that. You and I watched that TED Talk from Dr. Nadine Burke-Harris, and it really just solidifies why it's so relevant to think about some of the social things or environmental things or things that you don't think about as necessarily medical problems as our problem. Thinking about costs of healthcare. Everyone's worried about costs now, all the economic turmoil created by a pandemic and everything.
Mm-hmm.
So you wonder, do I need to order this test now? Do I need to do everything in this visit? Or can we do what, some of those who have access to medical care talk about, like incremental healthcare?
Yeah.
So I find myself thinking about costs a lot more. And it's interesting, and I don't know if you have a perspective on this, but when we're counseling with patients, because there's a lot of cognitive biases that come in, and a whole big talk about medical errors and biases. But I often encourage the residents to think about your plan, present it to the patient, and then have that discussion about that kind of negotiated goal setting. Is this everything you want to do? Because at the same time, while we're trying to do all of those things and be sensitive to the patient, we don't want to make assumptions about them. So we don't want healthcare disparities. We don't want to say, oh, I'm assuming because, you came in your t-shirt and jeans that you're, have a certain limited resources versus someone who's come in a suit and, professional going to work. I don't want to assume that, oh yeah, you'll be able to afford this treatment and you won't be. So have your plan and then negotiate it. And I think as much for their clarity, the residents' clarity, because you can make so many assumptions in that moment and then come up with a plan that doesn't necessarily make sense. But if you have your plan and then negotiate it, then it makes sense. And you're not getting so much disparity in healthcare.
But if you have your plan, which would be a plan that would be true for anybody walking in the door with the exact same symptoms, in other words, if you could turn it into a robot, an AI, and so that you've got no biases about how they look, how they're dressing, what accent they have, what color their skin is, you
Yeah.
know, what color their hair is. The bias in anything isn't there. So let's take that plan.
Yep.
And you're negotiating it.
Yep.
How can that person decline large parts of the negotiation? You have a plan that goes from A to wherever it goes, and they say, I'll take A and B. And if A and B show certain results, they're going to have to come back for C and D. So maybe you want them to do A, B, C, D because it's a one-time thing that will work together.
Yes.
So now we've complicated our negotiations. And do they get to say, well, no?
And here it comes to, it depends. And this is where the conversations are longer than 5 minutes. And that's, I think it's okay. We can keep talking, but if you have a diabetic patient and their A1C, their sugar control isn't great and it's 12. So maybe, and they're on an oral medication or they're on 2 that have been known to work together. And really your next step is either insulin or some of the newer medications. If you are comfortable and you think something like the newer medication, and I will use a brand name just for, like something like Victoza would be better, then maybe you want to recommend that and then see what insurance covers and if that copay is acceptable to you and all of that, as opposed to just saying, I don't think this is so expensive, let's just go with the cheaper one.
Ah, okay, okay. And if they say, I've got to go home and check with my wife, my son, what do you say?
Okay. Because people really need to have some sort of buy-in, some understanding, and some support. When we had been talking with the social worker about incremental care, I recently had that visit to the vet with a little stomach bug, and my vet wasn't in, so we didn't have a relationship. And she thought his belly was tender, and I didn't really check, but I didn't think his belly was tender, but I was concerned there was a bit of an obstruction because he had swallowed something. And so it was x-rays, stat blood work to see what the pancreatic enzymes were. And the x-rays were normal, thank God. And, and it was an $800 bill. And I think if I had seen my vet, because we have a long history, and he knows I will watch the dog like a hawk. I'm not going to get lost to follow, he knows all that I think he probably wouldn't have done that.
Yeah.
But technology and all of those things and the test results and the concern of liability all make people rush through the workup.
So part of the incremental care is also having a long-term relationship can help that move forward because of the trust that's involved there.
Yeah.
And so somebody's behavior in a medical setting can vary by long-term togetherness, so to speak, of the doctor or patient.
Yep. An understanding. And it's a little bit different than that plan. It's a little bit different than what I talk about with the residents. Have your plan and then adjust it. But what I hope is just knowing that there's that moment, there's that space after you present your plan for a little bit more conversation.
There's that space again.
Yes.
Yeah.
So
Yeah.
it's something that I don't know how much it answered your question. but it opens up so much, so much.
It does. It does. And I think if we come full circle to the beginning of my question, because that really answered a lot on the backside of the question, was, yeah, we are second guessing ourselves, and for a good reason.
Yeah, I was going to say, like, I
And
just want to
second guessing is a healthy thing. It's not a bad thing.
absolutely.
Even if it brings up bias, we can then, that's a way to address our bias.
Yeah. You always want someone thinking twice about your test results.
Yeah.
We counsel the residents on that too, because it's like, oh, we went over it and that pancreatic enzyme was a little bit elevated, but not really concerning. But maybe, and they start to think of another disease, and I'm like, it really is okay to call that person back.
Mhm.
People love to know that you were thinking about them and your gut reaction
Mhm.
wasn't sitting right. That's that little voice you want to listen to, and it's okay. And so many times they're concerned about, how do you tell the patient that maybe I wasn't 100% correct out of the gate, and we need to think of other things. And it's very doable.
As what we're really talking about here is behavior in the medical setting of the medical personnel.
Yeah.
Yeah, that's good. Okay.
Well, thank you.
Yeah, thank you for answering my question, because I think about it a lot.
Okay, good.
Bye.
Bye.